So today's class for the valvular heart disease, and we have divided this class into two sessions. Today we will be discussing about mitral valve and tricuspid valve, and in next class we will be discussing about aortic and pulmonary valve. So let us start with the management of mitral and tricuspid valvular diseases. Management of mitral and tricuspid valvular disease, and this will be discussed in mainly two parts. One is diagnosis and another is treatment. And diagnosis will be of two kinds: clinical diagnosis and investigation based diagnosis. Investigation based diagnosis. And treatment will be of two parts: medical treatment and interventional. Now starting one by one. First of all, we will start with the mitral valve disease. This will be of two types. One is mitral stenosis. Stenosis means narrowing of the mitral valve, and another will be mitral regurgitation is backflowing. It means somehow the mitral valve has been dilated, and that's why there is backflowing. So let us start with the mitral stenosis. First of all, diagnosis of mitral stenosis. Diagnosis of mitral stenosis will be clinical, as I have already told, clinical, and number two will be investigation based. Investigational diagnosis. Now coming to the first one, clinical diagnosis of mitral stenosis. How we do it with the help of our clinical knowledge. So clinical diagnosis of mitral stenosis. Clinical means what we do practically. For all practical purpose, clinical diagnosis of mitral stenosis is equal to auscultation. So what are the findings in auscultation in case of mitral stenosis? First of all, there will be loud S1. Because S1 is produced because of the opening of the mitral valve. Opening and closing of the mitral valve causes S1. So the force needed to close the mitral valve is now greater because the left atrium is already enlarged because of the stenosis. There is accumulation of blood in left atrium. So to close the mitral valve, more force is needed to close the mitral valve, and that's why S1 becomes loud. There will be opening snap. Opening snap. Opening snap. Since left atria is already dilated in case of mitral stenosis, so there is also a sound appears in the case of opening of the valves. Normally there is only heart sound, normal heart sounds like S1 and S2 are produced due to closing of the valves. But in case of mitral stenosis, where the left atrial pressure is already enlarged because of the accumulation of blood in left atria, there is sound in case at the time of opening also, because left atria is already dilated, and opening it further means stretching it further creates a sound that is called opening snap. And third is more important, low pitched mid diastolic murmur. Low pitched mid diastolic murmur, which is heard at the cardiac apex, and its characteristic is it is accentuated by exercise and during atrial systole, which is called pre-systolic accentuation. Low pitched mid diastolic murmur, and it is characterized by accentuation with exercise. Little exercise like some jogging or some walking for few steps in the ward itself will increase the intensity of this murmur. It is accentuated by exercise and also during systole, which is called during atrial systole, which is called pre-systolic accentuation. So these are the clinical findings: loud S1, opening snap, and low pitched mid diastolic murmur. How you will assess that it is loud S1? In mitral area, whenever there is mid diastolic murmur and there is loud sound at mitral area, that will be loud S1. And opening snap, this opening snap comes after S2. S2 is the second loud sound in the mitral area in case of mitral stenosis. That will be S2, and the opening snap comes after second heart sound. So we have that it is called A2. A2 followed by opening snap followed by mid diastolic murmur. This is the sequence: A2, opening snap, and mid diastolic murmur. So this is the sequence: loud S1, opening snap, and low pitched mid diastolic murmur. These are the clinical diagnosis of the clinical findings of the mitral stenosis. Now, investigation based diagnosis. Investigations in case of diagnosis of mitral stenosis. In fact, for all valvular heart disease, there are 5 basic investigations which will be sufficient for catching the diagnosis, and they are: number 1, ECG; number 2, chest X-ray; number 3, echo; number 4, Doppler; and number 5 is cardiac catheterization. These are 5 basic investigations which diagnoses all the valvular disease, not only mitral but also aortic pulmonary tricuspid. So let us start with the ECG in case of, I should keep it as such and I will dictate chest X-ray. So, in case of mitral stenosis, ECG, what are the ECG findings in case of mitral stenosis? First, in mitral stenosis, there is development of pulmonary arterial hypertension, and that leads to right ventricular hypertrophy. Pulmonary arterial hypertension is the complication of mitral stenosis, and that leads to right ventricular hypertrophy. So we get in ECG signs of right ventricular hypertrophy. Signs of right ventricular hypertrophy are tall R waves in V1 to V3. Normally V1 to V3 S wave is more deeper than R. But in case of right ventricular hypertrophy, tall R waves in V1 to V3. These are the signs of right ventricular hypertrophy which can be found in mitral stenosis. Number 2, there will be P mitral. P mitral means notch P wave. P mitral. Second finding in ECG will be P mitral. And third, there can be atrial fibrillation. Atrial fibrillation, there will be loss of P waves, and the rate will be irregular. So, tall R waves, P mitral, and atrial fibrillation. These are the 3 important findings in case of mitral stenosis in ECG. In chest X-ray, what we can find in chest X-ray? In chest X-ray, there will be enlarged left atrium and appendage. Enlarged left atrium and enlarged left atrial appendage. And number 2, there will be pulmonary venous congestion. In mitral stenosis, there will be back pressure on pulmonary vein, and that will lead to pulmonary venous congestion. So, enlarged left atrium and appendage and pulmonary venous congestion, these will be the two findings in chest X-ray. In echo we can have thickened immobile cusps. Mitral valve cusp may be thickened and immobile. Thickened immobile cusps, reduced valve area. Reduced valve area. In case of severe mitral stenosis, the valve area becomes less than or equal to 1 centimeter square per meter square body surface area. So reduced valve area, enlarged left atrium, and fourth finding in echo will be the reduced rate of diastolic feeding of left ventricle, because there is already a stenosis. The doorway to left ventricle is already narrow, so there will be reduced rate of diastolic feeding of left ventricle. So these four will be the findings in echo. In Doppler measures pressure gradient across mitral valve. So in mitral stenosis, the pressure gradient will be more. So And number two, it measures pulmonary artery pressure. So in case of complications of pulmonary arterial hypertension, in Doppler there will be pulmonary arterial hypertension finding. So it measures Doppler finding in the mitral stenosis. So what we see in Doppler is we measure the pressure gradient number one is pressure gradient across mitral valve. Number two, pulmonary arterial pressure. And number three, left ventricular function. So these are three things which is obtained through the Doppler. And the next diagnostic modality is additional information from the textbook. For I can repeat the measurement of pressure gradient in case of mitral stenosis by Doppler, that signifies in mitral stenosis
स्ट्रक्चर बताओ। जब कलर डॉपलर आप बताते हैं तो मिट्रल वाल्व का जो चेंजिंग होगा सीवियर एमएस में वो कैसा शेप क्या हो जाएगा, स्ट्रक्चर चेंजेस बताइए। ये मैं अभी नहीं बताना चाहता, बाद में बताइएगा क्या करेंगे।
एक्चुअली हम ब्रॉड आउटलाइन दे पाते हैं क्योंकि यहाँ पे जो हम लोग सब कुछ तो देख नहीं पाते हैं, कर नहीं पाते हैं।
बात सही है। बाकी
इसके बाद मेजर focus is to teach the in management part what actually we do here, because all the investigation modality are not available here and neither our patient
मेरा क्या फोकस हम जो बोलना चाह रहे हैं, मेरा फोकस है एमएस का पेशेंट सीवियर एमएस का है, क्या लेकर प्रेजेंट करेगा, क्या आपको क्लिनिकल फाइंडिंग मिलेगा, क्या इन्वेस्टिगेशन मिलेगा, क्या आप उसका ट्रीटमेंट करेंगे। तो जैसे आप डॉपलर तक आ गए, डॉपलर में सही है, डॉपलर में क्या चेंजिंग आएगा, चेंजिंग तो हम लोग बस पढ़ लेते हैं, बाकी ये लोग बताइए कि चेंजिंग क्या आता है डॉपलर है। जैसे उसका बटन ऑन हो जाता है, फिश ऑन होता है, कैसा होता है, एंटीरियर लेग का क्या मूवमेंट होता है, पोस्टीरियर लेग का मूवमेंट होता है। तो ये लोग एमबीबीएस पास होता है, ये लोग को वो बताइए, इसके बाद आगे मैनेजमेंट कर देंगे। हम इंटरप्ट नहीं कर सकते।
This is how we do our quality of class. I appreciate your feedback and I will try to include these things in next.
आप पढ़ाइए पहले, जो तैयार हो के तैयार करके आएंगे। अच्छा है।
It also measures pulmonary artery pressure, because as I have already told you that in case of mitral stenosis, there is chances of development of pulmonary arterial hypertension, and through this cardiac catheterization we can also measure pulmonary artery pressure, and by means of that we can assess the severity of the pulmonary arterial hypertension or whether it has developed or not. That can also be found. And number three, through cardiac catheterization itself we can know whether there is mitral stenosis or mitral regurgitation.
कहाँ से जाएगी catheterization?
Valvular disease. Through cardiac catheterization, we can find the associated coronary artery disease, pulmonary artery pressure, and valvular disease itself, whether it is regurgitant lesion or stenotic lesion. And now the treatment part. treatment of mitral stenosis. It can have two parts. One is medical treatment, and another is interventional treatment. In medical part, we have to look for primary three things. Number one is anticoagulation. Anticoagulation to prevent systemic embolization. And number two, beta blockers. For anticoagulation, we generally give vitamin K antagonist as per the books. Vitamin K antagonist because that is safer one, warfarin, and that can be given indefinitely if the patient has not done any other interventional surgery or any other interventional procedures. Beta blockers to control ventricular rate, and diuretics to control pulmonary venous congestion, because in mitral stenosis there is pulmonary venous congestion. So these are three basic treatment modalities, medical treatment modalities: anticoagulation to prevent systemic embolization, beta blockers to control ventricular rate, including atrial fibrillation, and diuretics to control pulmonary venous congestion. And interventional part is also important, because whenever our patient is young and they can afford, then we should go for interventional part also. Interventional treatment will be of two kinds. One is called valvuloplasty, and another is called valvotomy. Plasty means repair, and valvotomy means replacement. And treatment of choice is still valvuloplasty. Valvuloplasty is the treatment of choice, and when we do valvuloplasty and when we do valvotomy. So criteria for valvuloplasty. Criteria for mitral valvuloplasty. Number one, when there is significant symptoms. Symptoms are very severe, intractable. We are giving diuretics, still patient is dyspneic, and then his edema is intractable, not responding to diuretics at all. So significant symptoms. Number two, isolated mitral stenosis. Number three, trivial or no mitral regurgitation. And number four, non-calcified, mobile, non-calcified valve and sub-valve apparatus. Means mobile valve should be mobile, non-calcified. And number five, left atria should be free of thrombus. So these are the 5 criteria for valvuloplasty, and we do criteria for valvotomy. Valvotomy means replacement of the mitral valve. When there is significant mitral reflux, means there is predominant regurgitant lesion. When there will be predominantly regurgitant lesion, we will go for mitral valvotomy, means replacement. And number two, then the valve will be calcified and rigid. In rigid and calcified valve, there is no meaning of repair of the valve, that valve has to be replaced. So the criteria for valvotomy will be significant mitral reflux, and number 2, calcified, immobile and calcified valve. So these are the treatment modality for mitral stenosis. And now coming to the mitral regurgitation. First, mitral regurgitation. So diagnosis part. Diagnosis. Number 1 is clinical diagnosis. Clinical diagnosis. Clinical diagnosis practically in serious, it boils down to auscultation finding. In auscultation, we find apical pansystolic murmur. Apical pansystolic murmur, and it has some characteristics. It radiates to axilla and may be accompanied by thread. May be accompanied by systolic thread. It radiates to axilla, and may be accompanied by systolic thread. Number 2, loud S3, because of the forceful feeling of the left ventricle. There is vibration of the left ventricular wall, and that creates loud S3. And since the in regurgitant lesion, the valve ring is already dilated, so S1 will be soft S1. So these are the 3 important clinical findings which through which you can catch the mitral regurgitation. Apical pansystolic murmur which radiates to axilla, and you may palpate a thread, and loud S3 and soft S1. And now the investigation part through which we can diagnose. Investigation. As I have already told you, there are 5 basic investigations which catches the all valvular disease. Number 1 is ECG. Number 2 is chest X-ray. Number 3 is echo. Number 4 is Doppler. Number 5 is cardiac catheterization. So, in ECG, in mitral stenosis, we get P-mitral and atrial fibrillation. These are 2 important findings: P-mitral and atrial fibrillation. There will be notched P wave, and atrial fibrillation there will be loss of P waves and irregular rhythm. So this will be the ECG finding. In case of chest X-ray, we will get enlarged left atrium, enlarged left ventricle, signs of pulmonary venous congestion and even pulmonary edema. Pulmonary venous congestion and pulmonary edema. These are the 4 important findings in chest X-ray. In echo, we will get enlarged left atrium, in echo also, enlarged left ventricle, dynamic left ventricle, and structural abnormalities of the mitral valve. Because in case of mitral regurgitation, there is in case of regurgitation, there are chances of complications like infective endocarditis. So we may get vegetations, we may get prolapse of the cuspal rupture or caudal rupture. So there may be other structural abnormalities which leads to regurgitated lesion. And in Doppler again Doppler measures pressure gradient across mitral valve, pulmonary arterial pressure, and left ventricular function. These are the three things which are fundamentally looked through the Doppler. And through cardiac catheterization, we can assess the associated coronary artery disease. Again, pulmonary arterial pressure is measured through this, and whether there is regurgitant lesion or stenotic lesion, that is also obtained through the cardiac catheterization. And now the treatment part of the mitral regurgitation. And one thing that I forgot to tell, after valvuloplasty or valvotomy, we have to monitor the patient through Doppler echocardiography 1 to 2 yearly to rule out the re-stenosis, because re-stenosis happens very frequently even after valvuloplasty. So 1 to 2 yearly screening through Doppler echocardiography for the assessment of re-stenosis is also warranted. And now the treatment of mitral regurgitation. So first, the medical treatment. Number one is diuretics. Diuretics to ease the pulmonary congestion or pulmonary edema. Anticoagulants to prevent systemic embolization, because in atrial mitral regurgitation too, the complication of atrial fibrillation happens, and that might lead to the embolization, systemic embolization. So diuretics, anticoagulants, digoxin is given for atrial fibrillation. Although it is, but still textbook says to give digoxin in case of atrial fibrillation, to treat the atrial fibrillation. And vasodilators are also given when there is hypertension in case of mitral regurgitation. So diuretics, anticoagulants, digoxin, and vasodilators. Anticoagulants are also are fundamentally given when the patient is in atrial fibrillation. So for atrial fibrillation, there are two drugs which are important. Anticoagulants, and primary purpose of anticoagulants is to prevent embolization due to atrial fibrillation. So it might seem somewhat awkward that treatment for atrial fibrillation is anticoagulant, but yes, it is given. If you will be asked in your NEET examination, can atrial anticoagulant be used for atrial fibrillation treatment? The answer will be yes. Yes, because atrial fibrillation will lead to systemic embolization, and to prevent that, we need anticoagulants. And digoxin also is given for atrial fibrillation, and vasodilators also has role. Vasodilators if there is hypertension in case of mitral regurgitation. Now the interventional treatment. Interventional treatment is again the same as it was for mitral stenosis. That is uh, valvuloplasty, and valvotomy. In case of mitral regurgitation, also the treatment is of choice is valvuloplasty, and the criteria is same. And valvotomy, the criteria is still the same. Remain regurgitant lesion. Although in regurgitation there will be, yes, if there is associated MS and MR also, and MS is predominant, then again we go for valvuloplasty. So valvuloplasty ultimately becomes the treatment of choice, interventional treatment of choice, both in mitral stenosis and mitral regurgitation. And now very short description about tricuspid stenosis and tricuspid regurgitation. There is nothing more to discuss about them. And mainly tricuspid valve disease are associated with aortic and mitral valve diseases. And most of the time, predominant region becomes the mitral or aortic disease. And therefore, their assessment is somewhat clinical difficult. But if one is particular about that, then it can be easily discerned. So, tricuspid stenosis. And there is one important endocrine condition in which this is found, tricuspid stenosis. Isolated tricuspid valve disease is very rare. It is usually found with the other valvular disease. But isolated tricuspid stenosis can be found in one condition which is called carcinoid syndrome. That is due to oversecretion of serotonin. So, in tricuspid stenosis, the first finding, auscultation finding is clinical diagnosis. That is, auscultation finding will be mid-diastolic murmur at the left or right lower sternal border. And in case of mitral stenosis, is what? Apical murmur. The same character of murmur, but at the left lower sternal border, or sometimes maybe at the right sternal border. That will be of tricuspid stenosis. That is the clinical finding. Mid-diastolic murmur or simply diastolic murmur. Mid-diastolic murmur heard at the left lower sternal border. That is tricuspid stenosis. And it can be also diagnosed through investigation, Doppler echo. Through Doppler echo also it can be diagnosed. And its treatment is usually the treatment of the associated other valvular disease, and any process like valvulotomy or valvuloplasty for tricuspid valve disease is done simultaneously with the associated mitral or aortic valve disease. Means for mitral valvuloplasty, at the same time tricuspid valvuloplasty will be done. There is no separate session for the same. So this is, and treatment is same. Treatment part is medical treatment and interventional treatment. So medical treatment is the treatment of other valvular diseases, and interventional treatment is same as valvuloplasty and valvotomy. So this is about tricuspid stenosis, and last but not least, tricuspid regurgitation. Tricuspid regurgitation. Tricuspid regurgitation is mostly functional. most of the time it is functional, it is not organic. That's why treatment of heart failure in case of mitral stenosis or mitral regurgitation or aortic stenosis means any associated valvular heart disease leading to cardiac heart failure. So treatment of cardiac failure itself cures the tricuspid regurgitation. But its auscultation finding diagnosis, clinical diagnosis is again auscultation. In auscultation we find pansystolic murmur, systolic murmur at left lower sternal border. Pansystolic murmur at apex is mitral regurgitation, which radiates to axilla, and pansystolic murmur at left lower sternal border, that is tricuspid regurgitation. And its clinical diagnosis is through auscultation, and investigational diagnosis is again through echo. In echo we can easily get the tricuspid regurgitation, and treatment is also since it is mostly tricuspid regurgitation is mostly functional, therefore treatment of the cardiac failure itself cures the improves the tricuspid regurgitation. And when it is structural, the treatment is same: valvuloplasty and valvotomy, and that is done simultaneously with the mitral or aortic valve disease, the predominant lesion with which it is usually associated, because isolated TR and PS are rare. So this was all about